hang around until the end, and I'm going to hand over to Mati, who's going to introduce Susan. Thank you very much for a brilliant talk.
Right, thank you so much, Prof. That was really a fantastic introduction into this webinar. So we're now going to listen to Dr. Susan Murphy, who is also a pediatric intensivist, and she has been a consultant in the ICU for more than 10 years now at Baragwanath Hospital, and she's also a senior lecturer at WITS. And one of her many interests are electrolytes and fluids. And I really hope that this is going to merge very nicely, and I know it's going to merge very nicely with Prof's talk. And thank you so much for being willing to talk to us today. Thank you, Susie.
Hi, everyone, and thank you so much for giving me the opportunity to chat today on the webinar. So the second half of this webinar is going to address electrolytes and fluids. And this is a topic that is fraught with controversy, simply because there is so little consensus on clinical management when it comes to fluids in particular, as well as electrolytes. And there's a lot of conflicting data out there. And with particular clinical scenarios, and the one that probably troubles clinicians most frequently is the child who comes in dehydrated with hyponatremia. For that particular clinical scenario, there's really also not a lot of good evidence to indicate what sort of fluid we should be using and what is the safe rate of correction of the serum sodium. And so there's a lot of opinion, not so much data, which makes it a tricky topic. In this talk, what I'm going to try to do in the first part of the talk is introduce a couple of new perspectives, possibly for some of you, and new reconsiderations about how to think of fluids. And I'm going to question some of the dogma, the stuff that we've been taught over years and years and years, particularly with regards to the volumes of maintenance fluid for children, and what is the ideal fluid. And then in the second part of the talk, I'm going to deal with some of the common electrolyte abnormalities, particularly focusing on hyponatremia and hypernatremia, because those are probably the most common that we find. And then due to shortness of time, I'm going to touch briefly on potassium abnormalities, and I probably won't be able to cover the not so minor electrolytes. So the first thing I'd like you to consider when it comes to intravenous fluids is to change your perspective of how you think of them and to consider them as being drugs. And I'm not the first one to bring this idea, to introduce this idea. There's a lot of people who have been encouraging us to think of it in this way, and it's a very useful way to think of them. And interestingly, I found that fact that there are more adverse events from fluid administration than any other drug. And just like you wouldn't prescribe drugs to your patients without there being a specific indication, so it should be the same when it comes to fluids. And we always say, we talk about maintenance fluid a lot, but in most cases, we shouldn't be prescribing intravenous crystalloid as maintenance for our patients, but we should be giving them maintenance food. So in all cases, enteral feeding, enteral nutrition is the best way to give your patients fluid. Having said that, there are times when you do need to give your patients maintenance fluids, the patients who are not being fed or who have gut failure for one or another reason. And in each case, you should consider your prescription, and the dose, composition, and duration should be tailored specifically to that patient's pathophysiology and underlying medical condition. And it should always be discontinued when it's no longer necessary. And just as we would do therapeutic drug monitoring for our antibiotics or other drugs that are prescribed for patients who are receiving large volumes of crystalloid, it's essential to monitor the electrolytes, particularly your sodiums, potassium, and urea and creatinine in these patients. So, first part of this dispensing with the dogma, the traditional calculations that we have been taught as pediatricians and that are still being taught today in terms of how to work out maintenance fluid requirements for children comes from this paper published by Holliday and Sager, which is almost 60 years old now. And I'm not the first one to question this, and I would like to refer you to these papers that I've referenced in the bottom of the slide, which are very useful for you to read. And we've been traditionally taught that fluid requirements, we give 100 moles per kilo for the first 10 kilograms of children's weight, followed by 50 moles per kilo for each kilogram in the next 10 kilograms, and then 20 moles per kilo. Or another way of working it out, we taught the 4-2-1 rule if you work it out in moles per kilo per hour. But it's useful to look back at how Holliday and Sager came to these fluid volumes that we've been using. And how it actually came about was it started off as an estimate of caloric requirements for hospitalized children. And if you read their paper, they basically, what they did was they plotted on a graph basal energy expenditure for children at particular weights and ages. And then they looked at the energy requirements in normal children. And then they kind of guessed, and they do say in their paper that they guessed that sick children would fall somewhere in between those two curves. And initially, it was about calories. So the 100 per kilo per day was actually calories that they were working out. And the 150, 20 was all about calories. And they said you need the equivalent amount of water because with each 100 calories that are metabolized, you produce 50 moles of insensible losses, 66.7 moles of urine, and you use up 16.7 moles in metabolism. And so that's how the 100 calories became 100 moles per kilo. But we know now from how we understand physiology, particularly in sick children, and from data published in the last couple of decades, we know that these formula overestimate energy requirements for hospitalized children quite significantly. And that the caloric requirements are more in the range of 50 to 60 kilocalories per kilo per day. And in critically ill children, even as low as 40 kilocalories per kilo per day. The other thing about the Holliday and Sager calculations is that they overestimate urine output. And we know that sick children have this inability to excrete electrolyte-free water. And there are a lot of non-osmotic stimuli which result in ADH production in these sick children, which means that they can't deal with large volumes of water effectively. And I think the urine output that was estimated in the Holliday and Sager was 3 moles per kilo per hour. And it's very unusual for you to find an ill child who's producing that amount of urine in the absence of a diuretic being prescribed. The insensible losses are probably overestimated as well. And we know that in normal children, the insensible losses are around 30 moles per kilo. But in the critically ill children who are in an environment which is where they're quite thermoregulated and they have humidification, either through the oxygen that they're receiving or the ventilation, their insensible losses may be as low as 10 moles per kilo. And so probably the amounts or the volumes that we traditionally have been prescribing for children are much larger than what they actually need. And this is important because fluid overload is a significant problem. And there's good evidence to show that fluid overload in your sick children is associated with increased morbidity and mortality. And that's particularly obviously in the critically ill kids, but also those with acute lung injury. And your goals should be to maintain effective circulating volume with normal electrolytes and to try and avoid this from happening. So, second part of the dogma that we need to address is what is the best maintenance fluid for children? And as I mentioned before, you should always try to feed children enterally. That is the best maintenance food and not maintenance fluid. But there are instances when it is necessary. And Holliday and Sager advocated in their paper for using hypotonic fluid. And they estimated the sodium requirements to be equivalent to what is found in cows and breast milk. And for a long time, very hypotonic fluid pediatric maintenance solution was prescribed. Unfortunately, that is no longer being used so much in practice due to the fact there's been a lot of evidence showing that the severe consequences of using these very hypotonic fluids, in particular causing cerebral edema. But it's not uncommon for patients in the pediatric setting, and I know even in big teaching hospitals, that hypotonic fluids are still prescribed as maintenance fluids for children. And the ones that are commonly used are rehydration solution and half Darrow's. So I've put this table up here and basically showing you the different compositions of the types of fluids that you may commonly find in hospitals or prescribed for children. And I'd like to bring your attention to this concept of tonicity. So tonicity differs from osmolality, and it's an important concept to understand. So osmolality is, as we know, the amount of solute per kilogram of solvent, which is able to exert per kilogram of solvent. And tonicity differs from osmolality in that what tonicity is it is the effective osmolality. So it only takes into account those osmoles that are able to exert an osmotic force across a membrane. So substances such as glucose and urea, which are able to freely cross the membranes, don't contribute to tonicity. And so you can see with half Darrow's, the osmolality is quite high, and that's because of the high dextrose content in this fluid. But the tonicity, or the effective osmolality, is quite low. And this is important because isotonic solutions, which are those that have tonicity, which is pretty much in line with what you find in plasma, are going to be isotonic with reference to your cell membrane. And the result of that is when you give them to patients intravascularly, they're going to tend to stay within the intravascular space. Hypotonic solutions are hypotonic with plasma in reference to the cell membrane. And so they'll tend to move out of the intravascular space and into your intracellular and interstitial compartments. So if you have a look here at the options that we have for fluids that are isotonic, you've got normal saline, ringers, and balsam. Normal saline has got basically sodium and chloride in concentrations that are much higher than what is found in your normal plasma. But if you look at balsam, or plasmolite B is another name for it, or ringers lactate, you'll see that it's both isotonic, as well as the electrolyte compositions mimic that you find in plasma. So the sodium, potassium, and chloride concentration pretty much look like, as well as the buffer, bicarb in the case of balsam and lactate in the case of ringers, is pretty much similar to what you'd find in plasma. And this is important because probably the better maintenance fluid for children would be a balanced isotonic crystalloid. And the big argument or reluctance that people have had for not using these as maintenance fluids in children has been the argument that they increase the risk of hypernatremia because of the higher sodium load compared to something like rehydration or half Darrow's. But refer to these two reference articles below, and actually there's no evidence to show that the use of isotonic balanced crystalloids increases the risk of hypernatremia when used as maintenance fluids. And in actual fact, they're safe. And the isotonicity is of benefit because it means that fluid will stay in the intravascular space. The big disadvantage of these fluids is that they don't have dextrose, but you can easily remedy this by adding 100 moles of 50% dextrose to each bag, which will make it a 5% glucose solution. Your half Darrow's or your rehydration solution contain much lower or are basically hypotonic and have a higher risk for causing hyponatremia. And the evidence seems to indicate to the fact that it's not so much the volume of fluid that is the greatest risk for developing hyponatremia, but actually the tonicity. And the more hypotonic the fluid, the greater the risk for developing hyponatremia, which is why solutions such as Pediatric Maintenolite, which was basically a 0.2% saline solution, extremely hypotonic, have now been are not in use in large parts of the world. So it's not only me who's saying this, who's saying we should dispense with the dogma of giving hypotonic maintenance fluids. This is the American Academy of Pediatrics. This was published recently, and they recommend that in kids outside the neonatal period up to 18 years of age, we should be using isotonic solutions with appropriate potassium chloride and dextrose in these patients. And they've excluded neonates, obviously, in this group. And they've also excluded particular groups of patients, such as those with burns, with cardiac lesions, neurological, neuropathology, as well as those with profuse watery diarrhea. And in the UK, the NICE guidelines, again, basically they recommend that isotonic crystalloids should be used as maintenance fluids in children. And they've covered both bases by saying the sodium should be in the range of 130 to 154. So saying you can use normal saline or balanced crystalloid. And again, here you can see that they also mention the importance of restricting the amounts of fluids that we give to our patients, 50 to 80% of maintenance in those who have non-osmotic ADH secretion. So in the second part of this talk, I'm going to cover hypo and hypernatremia. And hypernatremia I'm going to start with because it is the most common electrolyte abnormality commonly encountered in hospitalized children. And I've put this slide first because it's often iatrogenic. We know that ill children have difficulty excreting electrolyte-free water, and that's because of the variety of things that can cause a non-osmotic release of ADH. And I've listed some of these causes in the top right corner here, and it reads like the common things that you may find in your high care or your intensive care units. Pain, simply being post-operative, morphine or other opioids being used, respiratory pathology, vomiting, head injury, being on the ventilator. In one study done in bronchiolitic infants, they found that 70% of them had difficulty excreting electrolyte-free water. And by the time they in the recovery period, their electrolyte-free water clearance increased to 15 times that it was in admission. So it's a combination of the fact that they have difficulty dealing with large volumes of water, your sick kids, plus the fact that probably traditional maintenance calculations are giving too much in conjunction with hypotonic fluid administration. So hyponatremia, true hyponatremia is associated with a low serum osmolality as well. And it can present either in a patient who is volume replete, and that would be classically your inappropriate ADH patients that we've spoken about previously. It can occur in a patient who is volume deplete and who is dehydrated together with hyponatremia, or it can also occur in a patient who's volume overloaded. Excuse me. And the common ones there would be patients with congestive cardiac failure, your liver cirrhosis patients with anasarca. They may have hyponatremia and actually be volume overloaded. And some other useful investigations may help, particularly looking at your urine sodium and fractional excretion of sodium, looking at the hydration status of the patient and other investigations. The important distinction, so there are some cases where you may actually be losing salt, and that's why patients are hyponatremia, your renal and cerebral salt wasting, classically. And the difference being that in those patients, they'll tend to have be dehydrated as opposed to inappropriate ADH, where the hydration is either normal or increased. And these patients have increased loss of sodium in the urine. And the treatment is different to inappropriate ADH, where we restrict them of the fluids. Here, you may need to give sodium. And obviously, the treatment will depend on the etiology, and it's really beyond the scope of this talk to go into that in detail. But what I am going to say is, in the case of patients with severe or symptomatic hyponatremia, you need to treat that quite as a matter of urgency. So these patients can develop cerebral edema and seizures. And you can work out the sodium deficit required using this useful formula, which will tell you the millimoles of sodium needed to get your sodium up to, and usually we use the lower level, so 130 to 135 as our desired sodium. And then the various types of fluids that are available, usually we would use something like 5% sodium chloride. If you don't have that, sodium bicarb has also got 1 millimole of sodium in it per liter. You would need a substantially larger volume of normal saline if you were going to use that. And that can be given quickly over like a 30-minute period in your patient who's symptomatic with severe hyponatremia. What about the patient who comes in with gastroenteritis, whose volume deplete with hyponatremia? So obviously with these patients, you need to take into account maintenance, rehydration, and ongoing losses. Maintenance, as I keep on saying, ideally if the patients can feed, enteral feeding or partly enteral feeding is the best way to give it. In the absence of that, isotonic balanced crystalloid for your maintenance. Your losses should be replaced with fluids that resemble the type of fluid lost in equal volumes. And so it's important to know where the losses are taking place. So the kinds of fluid that you might use for a patient with gastro would be different to, for example, a patient with high output ileostomy losses who is dehydrated. And then this is a personal recommendation that an isotonic balanced crystalloid initially. And obviously these patients are going to be the kinds of patients that you want to, you're going to need to monitor the electrolytes 4 to 6 hourly. And it's sufficient to do a blood gas to do that, to monitor the sodium increase. And we don't want the sodium to increase rapidly because of obviously the risk of osmotic demyelination. And so the recommendation that it be done slowly. And if you find that using an isotonic balanced crystalloid is not giving you a satisfactory rise, you could consider normal saline. There are a lot of people who recommend normal saline. Or if you find that it's increasing too rapidly, you could use a solution which has got slightly more free water. And I'd like to emphasize that this is obviously, it's not a one size fits all, and you may need to fiddle around a little bit to get the right thing for your patient. And the important thing is to monitor the electrolytes as you administer your fluid. Just a note on saline, so it's what I call abnormal saline, or so normal saline, 0.9% saline, which has got, as Prof mentioned, 154 millimoles of sodium and chloride, and it's isotonic. And this is often given to patients with hyponatremia. And the problems and it may be necessary, but there are issues with giving it with normal saline. And the one is the one that Prof Argent explained really nicely in his talk, is the hyperchloremic acidosis as a result of the increased chloride to sodium ratio that can occur. And the second factor is that there's evidence now to show that concerns about chloride and its effect on the kidneys, that it may not be great for your kidneys. There's some data which they did a study in patients, normal patients, and showed that infusing normal saline in these patients resulted in reduced renal blood velocity. There's been some literature in the critical care community to show that a chloride sparing strategy, in other words, using balanced crystalloids as opposed to normal saline, resulted in less acute kidney injury and need for renal replacement therapy. And as to how it's bad for the kidney, it's postulated that the high chloride reabsorption affects thromboxane and afferent renal artery vasoconstriction. So those are the concerns with giving normal saline, just to bear in mind. Hypernatremia is the second electrolyte abnormality, which I think is one that is commonly faced in clinical practice, and in particular the patients with hyponatremic gastro. Again, these patients may be volume deplete, and that would be these patients would be those that are truly dehydrated, so who have lost pure water or predominantly free water. But you may also find patients who are volume replete, so normal extravascular volume with high sodium. And that may occur in certain disease, in certain conditions. For example, where formula has been mixed very concentrated, or children have received medicines that have got high sodium content. Sometimes we're responsible as physicians or as doctors, as pediatricians. It's not only things like loop diuretics that can cause hypernatremia, but some of the other drugs which you may not consider, for example, tazocin. Tazocin has got 6 millimoles of sodium in each vial. So children prescribed very high doses of tazocin, you may iatrogenically increase the serum sodium. It may be a result of the types of fluids prescribed, boluses of bicarb, or a lot of medication, which may have been mixed in normal saline. So it's important to assess the clinical state of your patient and the hydration status, and look at all these sorts of things, as well as the diseases or underlying medical condition. We know children with CNS pathology, especially tumors and traumatic brain injury, might develop diabetes insipidus as a result of a vasopressin deficiency, and they lose free water and result in severe hypernatremia. And your management obviously will be tapered according to the cause. So those that are volume deplete will need volume replacement, and whatever they're losing, or wherever they're losing fluid, you should try to replace those losses with equivalent electrolyte composition. Your diabetes insipidus requires DDADP, and in some cases you might need to decrease the administration of sodium. I've put at the top of the slide the formula that we use for calculating the water deficit, or the free water deficit, which will give you, if you use that, we use a 60% body water composition, and that will give you how many liters of water these patients will need to correct their sodium if it is a deficit of free water that is the problem. The big dilemma, which I think is faced by clinicians in clinical practice, is the dehydrated child with hyponatremia, or our so-called hypernatremic gastros. And the problem is, as I mentioned in the beginning of the talk, is that there's not a lot of good evidence out there to say what sort of fluid we should be using, and also how safely can we lower the sodium. So there has been two papers published. One was actually locally, and team in Durban at King Edward Hospital, and there they use a protocol to treat hypernatremic gastro, where the sodium content of the intravenous fluid that they give is 2/3 of that of the serum sodium in the patient. And they found that dropping the serum sodium at a rate of 0.5 to 1 millimole per hour actually didn't result in a greater number of adverse events in their patient group. And in Israel, another study looked at rate of drop of sodium, and they found that it was safe to drop serum sodium in these patients at a rate of 0.65 millimoles per hour. So the problem with these kiddies is what they really need is free water, but it's dangerous to just give them free water, because you run the risk of precipitously dropping their serum sodium. So you also need some sodium to make sure that you don't decrease it too fast. And so the question is, what is the solution? And a lot of proposed that you use normal saline with dextrose added to it. But for the reasons mentioned about normal saline, there are issues with it, as I've mentioned before. And if you take into account the Durban group, what they did was they used that 2/3 of the serum sodium. And if you take that as guidance, unless your serum sodium is above 200, you can actually get away with having a sodium content of your fluid of around 130 millimoles per liter, which is what you find in your isotonic balanced crystalloids. And only when it exceeds 200, then maybe you need to give something with a higher sodium content, such as normal saline. So again, maintenance best given in the form of isotonic balanced crystalloid or feeds, and losses replacing with a solution mimicking the fluid lost. And half Darrow's is actually, in terms of the type of fluid, is not a bad solution because of its high potassium content here, and mimics gastrointestinal diarrheal losses. And then for rehydration, a pragmatic proposal that I would give would be to use an isotonic balanced crystalloid initially. And again, you're going to monitor. And if the sodium is not declining, then to consider adding fluid with a higher percentage of free water. And I've put on the right-hand side here the different compositions of different solutions with their free water. So tap water and 5% dextrose has got 100% free water, half saline, 50%, and normal saline, nothing, with the aim of decreasing by 10 to 12 millimoles per day. But possibly it may be safer from those two papers that we've read to reduce it at even as fast as 1 millimole per hour, but always to err on the more on the more sort of on the safer side and the lower side. And if you're finding that the sodium is declining too rapidly, then to obviously change to a fluid such as normal saline, where you have, which may result in a lower decline in serum sodium. And this is just a pragmatic proposal. And I think it's important to emphasize what I said in the beginning slide, is that it's not a one-size-fits-all strategy, and that fluids are like drugs and may need to be prescribed according to the specific needs of your patients. And doing your therapeutic drug monitoring, in this case, measuring your electrolytes frequently, 4 to 6 hours in the case of these sorts of patients, will allow you to make adjustments to your therapy appropriately. I've just put this slide in here to remind you of the electrolyte composition of the different kinds of fluids. And so, for example, high output ileostomies, you'll see we often use saline for these patients, normal saline, and sometimes add some potassium because we find that they do drop their potassiums. Your gastric patients, again, sometimes we use half normal saline for these patients, and half DARAs is not a bad solution for those with profuse diarrhea because of its high potassium content and the lower sodium content. So always bear in mind what you're replacing in these patients. And then we don't have much time, but just to run through potassium replacement, I'm not going to go into too much detail about the approach to hypo and hyperkalemia, but just to remind you of the different kinds of contents of potassium of your IV fluids. Generally, in the ICU, we replace it IV as a rider if it's below 2.5 at a rate of 0.3 millimoles per kilo per hour, and it's necessary to give that to monitor to check your potassium thereafter before continuing with the rider. So we generally run it over 4 hours. And then can be replaced orally as well. Just to point out that there's differences in the potassium content between the adult mist KCl solution and the pediatric solution. We use the adult suspension in our unit simply because we treat adults in our unit as well, but also because each mil is basically 1 millimole, and then so we give 1 millimole per kilo per dose comes to more or less 1 mil per kilo per dose, but you can also replace it in the form of slow K. And then hyperkalemia. Obviously, the two most important things are to make sure you stop any extra potassium containing fluids and treat the cause. And this may very well involve getting ready to start renal replacement therapy in the case of acute kidney injury, which is not when patients are anuric and not responding to medical therapy. The calcium chloride is given, as we know, initially. What it does is it lowers the threshold for action potential generation in the myocardial muscle, so makes it less excitable and less prone to arrhythmias in the face of the hyperkalemia. And then bicarb salbutamol, we found it useful in our unit to give it intravenously in a 4 mic per kilo dose. Lasix, obviously, if your patient's not passing urine, that might not work. And then we've had a couple of bad experiences with patients becoming profoundly hypoglycemic when using the dextrose and insulin shifting. And so we tend to sort of do that last. And just the important thing to remember is to monitor the sugars in those patients, not just once, but several times after the administration of that. And so that about wraps it up. So in conclusion, I think my take-home messages for you are to remember that fluids are drugs. And as such, there should be tailored prescriptions. There's no one-size-fits-all strategy. And if you're going to be giving them, you should be monitoring electrolytes. When it comes to maintenance fluids, ideally enteral is always best. And then your calculations will be based on the caloric requirements for your patients. Generally, less is better for most sick children, and isotonic balanced crystalloids are usually ideal, but there are always exceptions to every rule. And that's it. And then at the end, I've got a couple of references. I know this talk will be available to you later, maybe of interest to you for those who'd like to read up a little bit more. And that's it. I'm going to end there.
Thank you so much, Susan. That was really a great overview of fluids and electrolytes. There's lovely discussions going on in the chat, so that's really nice to see. So I'm going to, I'm sure most of you guys can see the chats, but some of the nice things that's come up is, why don't we just mix our own fluids? Why don't we just use Ringer's lactate and we always add dextrose to it? And I think the answers also come out quite nicely in the chats, is that anything that we mix, because it's a drug, whenever we mix something, we can easily make mistakes, and we can also introduce infections. So I don't know how you feel about using kind of a Ringer's based for as your maintenance fluids and then adding dextrose to it.
Yeah, so that's what we do in our unit. So we use either Plasmolite B or Balsol or Ringer's, and then we will add 100 mils of 50% dextrose to each bag. So we make it in a 5% solution. And that's what we've done for almost the last decade as our standard maintenance for our kidneys. It's a pity that there isn't a fluid. I keep on waiting for them to make a balanced isotonic crystalloid with dextrose for this purpose. But that's what we do, is we make our own solution. Yeah.
Great. And one of the questions in the chat is, should we actively correcting asymptomatic hyponatremia and severe malnutrition if the sodium is, for instance, less than 120, or during the rehabilitation and with respect to getting the patient to feed better? So I don't know what your feeling is about correcting sodiums if they are asymptomatic.
So, yeah, from what I've read and from what our practice is we only correct it if they're symptomatic. So if your child's having seizures or worried about level of consciousness and cerebral edema, then we would do that. But not actively, we wouldn't emergently treat it. I don't know if Andrew or any of the other guys on the panel want to comment on that.
I mean, just speaking from, again, an ICU perspective, I think both on children and on adults, hyponatremia is associated with worse outcomes. And I think if there's any hyponatremia, there are two things I'm doing. One is saying, why are they hyponatremic? What's going on? And try and deal with the underlying cause. But certainly I would be adjusting their fluids to make sure that it's slowly starting to move in the right direction. I don't want it to change too rapidly, as you pointed out. I mean, in the hypernatremia, you don't want it to be changing at more than somewhere between 0.5 and 0.1 millimoles per hour. I think the same is true for hyponatremia. You want that to be gradually coming up, because there are clearly problems and brain injury that are related to rapid changes on any of those things. Perhaps one other comment is that I think sometimes it's really useful to measure electrolytes in things like urine and so on, and just see, because it's, you know, if you discover that your patient is puddling out what looks like normal saline, then you're going to have to replace with something that looks like that. If your patient is puddling out something that's got very low sodium content, then you've got to be careful about putting too much sodium into that. And the other piece that I think is very useful in patients with fluid imbalances is not to focus entirely on the sodium, but also to look at the total body weight and the total body water, because that gives you some guess, you know, am I losing more fluid than I'm getting? You know, where am I on that balance? And so with a combination of regular measurement of the serum electrolytes, regular measurement of weight, and regular measurement of things like urine, you can start to fine-tune things to where they are on this patient. But I totally agree with Susan. I don't want it changing too rapidly. But by the same token, you know, being just under 135 is not okay. Being hyponatremic is associated with worse outcomes. I don't know if Susan would like to add to that.
Yeah, I did. Yeah, that definitely it is the case. And I actually had that written down as one of my important things, is the fact that, yeah, that it isn't benign, that there can be chronic problems long-term from that. And it is the most common electrolyte abnormality we see in hospitalized patients. Yeah.
Okay, and then there's a question from Philip Sneyman about what about K-Exolate? So what's the latest about K-Exolate for hyperkalemia?
So my understanding is that that's really only used in chronic hyperkalemic states because it takes a while to work. So, for example, like your chronic renal patients, the thing is, if you've got an acute hyperkalemic emergency, it's going to take time to do that. So we, in our ICU, I don't even know if it's even available at Barrow anymore, but we don't use that because it's going to just take too long. And it's those other strategies are far more effective. And then failing that, we would implement renal replacement therapy for a patient who has refractory hyperkalemia. But I suppose there may be some role in those with chronic, so like your chronic renal failure. Maybe Minion can comment on that. She's the renal guru.
I'd like to hear Minion.
So I don't know about being a renal guru, but the story on K-Exolate is interesting. So there's been some excellent work done out of the adult renal unit at Stellenbosch, where they've actually found that in adults you get colonic perforation with K-Exolate, and we know that we get the same in neonates. So a lot of the neonatologists have said, please stop using K-Exolate. I must say, if you've got an extremely high potassium and you do not have easy access to renal replacement therapy, K-Exolate may be on our recipe list, but it would definitely be down the bottom. So I completely agree. Salbutamol and frusemide are often the easiest things to get. Calcium and bicarb definitely. And then the same group under Rosine Davids at Stellenbosch has also done some interesting work looking at insulin, because we often have this discussion, the adults use insulin and dextrose and we don't, we just use dextrose. But they've actually shown that a lot of these adults are so stressed that they have a very high glucose level, and you don't actually need to give insulin because the insulin in their body is already pretty high. So I must say I've had the similar experience to you, Susan, in that there's been kids have been forgotten and people haven't done their glucose checks and they've suddenly become very quiet and well behaved, and it's because their glucose is often running at 0.1. So just something just to watch out for. And then just to comment on what Andrew was saying, I think going back to basics, doing weights if you possibly can, and very careful monitoring of fluid in and fluid out. So Stuart seems to be the name, so the strong iron theory, but also Stuart Goldstein came up with a very easy formula that looks at your initial admission weight and then you look at your fluid in versus your fluid out. And once you get more than 20% fluid overload states, your morbidity and mortality increases. So those are basic things that we can do. It doesn't need to be very fancy. And so I think less is more. And as Johnny put in the chat, fluid should be prescribed as a drug. It's not something that you just throw at kids. So thanks for a very nice presentation, Susan.
Susan, there's a lot more questions for you. You're not off the hook yet. So there's one specifically asking about when you bolus, what rate do you use? And then one specifically about, in the view of concern with strong ions and overhydrating ill patients, what are the recommendations for bolus volumes and time and type of fluids, like normal saline in the management of, like, for instance, hyponatremic dehydration, DKA, and septic shock?
So, I mean, this talk really focused on maintenance fluids. So the whole talk about resuscitative fluids is a topic for another webinar, because that really deserves time to be discussed, you know. But obviously, if you're talking about giving boluses in the acute resuscitative phase, with the aim of restoring circulating blood volume, so in your shocked patient, your trauma patient, then in the non-cardiac patient, then we would give sort of between 10 to 20 moles per kilo. And the important thing I think about doing that would be to always look for response. So identify a marker that you're going to titrate your response to, whether it's the tachycardia, the perfusion, the urine output, the level of consciousness. And then if you are seeing a response, then that means that that's the correct thing, and maybe your patient needs more fluid. And if you're not seeing a response, or you're finding that your patient is becoming galloping or developing a hepatomegaly, then that's obviously not the appropriate therapy, and your patient's shocked from another reason. So the importance of titrating fluid responsiveness. And we tend to use smaller, so I think in terms of the fluid, I think definitely colloids are out, so there's no role for colloid. And the recommendations, I think, from the sort of surviving sepsis and the sepsis guidelines are isotonic crystalloids would be your fluid of choice. And obviously it depends on what's available in your hospital as to what you would use. The complications with normal saline are not benign, and we regularly see patients with DKA who've received 4 liters of normal saline before coming into the ICU, and then have, wonder why the acidosis is not getting better. So again, our personal preference is the balanced crystalloids, but any isotonic crystalloid would be appropriate in the resuscitative phase. Yeah.
Perhaps if I could just comment, I think a few years ago we would have been much more aggressive in terms of the boluses that we would use for resuscitation. I think the trend has been to people being a little bit more cautious, and people are talking about using volumes of 10 per kilo, see what actually happens. And I think what people are also talking about is starting to use inotropes such as adrenaline earlier, rather than giving huge volumes of resuscitative fluid. There's been quite a lot of work looking at the physiology of children with sepsis. And it's clear that some of those children actually have quite good cardiac output, and their problem is low systemic vascular resistance. There's evidence that on some children, if you give them boluses, the blood pressure goes up a little bit, but you know what? The cardiac output is back to what it was within half an hour of giving the bolus. So I think there's much more emphasis on cautious bolus administration. People seem, certainly in the adult world, to think that the balanced salt solutions are probably better than the saline, but if saline's what you've got, there you are. But there's more and more emphasis on saying, measure the responses, look for it, and for heaven's sake, if your patient is starting to become overloaded, stop giving lots of extra. And the other piece to add into that is, you can get your knickers into knot about whether you give a bolus of 10 or 20 per kilo. But if you're then going to give maintenance fluids of 100 mils per kilo, and then you're going to add a little bit of blood product, and then you're going to add a little bit of inotropes and a little bit of medication, you suddenly find that you've given a very large volume. And so part of it is keeping track of all the fluids that you're giving and where that's actually going. But Susan's exactly right. So thank you.
So just thank you for that, Prof. So 2 questions to quickly address. So someone is asking about calcium gluconate 10% in hypokalemia, and I think it depends on what your unit has. If you've got calcium chloride or calcium gluconate, you can definitely use that for the treatment of hypokalemia. And then someone is also asking about phosphate, and that's often something that you struggle to find is oral phosphate in the smaller units. So she's asking, what else can you use to replace this besides potassium phosphate IV when oral is not an option, like in surgical patients? So I don't know if you know about any formulations that can be given IV.
So as far as I'm aware, it's only the potassium phosphate IV, and then if we need to replace orally, we usually use the phosphate fleet enema, which we know has got about 220 milligrams per mol. And we give between 30 to 90 milligrams per kilogram per day in divided doses. So we use the phosphate fleet enema orally. So I don't know what you would use if you've got gut failure. I'm presuming if you can't take orally, you could speak to a dietitian. I know there is phosphate, in terms of what TPN they use. That might be, just have a discussion with the dietitian. But as far as I'm aware, there's only potassium phosphate IV available
And
us.
the other agent that is also available, but again it's oral, but maybe slightly better absorbed, is phosphate sandos, the effervescent variety. So it comes and goes in government pharmacies. So it's just something to look out for. But strangely enough, a lot of people use the phosphate enema as an oral agent as well. So that's a good option. But then your TPN is the other option. I agree with you.
Great. And just one of the questions that I would like Prof. Arjun just to elaborate on is, when do you decide to treat a metabolic alkalosis? I think you addressed it a little bit, but it would be nice to just get your view.
Okay, so I think for me, the first thing is that alkalosis is not benign. It does affect all sorts of things, both at an intracellular level, at an enzyme level there. So alkalosis is not great. I think for me, the first step is understanding why they're alkalotic. And certainly at a place like Red Cross, probably the most common reason is diuretic therapy. It's literally that we've been giving them lots of Lasix and diuretics, and they're puddling out large volumes of chloride, and that's where it is. I think part of my reaction to, metabolic alkalosis is, if it's mild, I would simply see if I can take away the cause or address the cause, back off on the diuretics if I can, add a little bit more chloride to the fluids that they're getting from there. I just know that when you get to treating it, what you're needing to do is to increase the chloride to sodium ratio in the fluids that they're getting and gradually put it in. But you know what? If the metabolic alkalosis has developed over weeks, there's no frantic urgency to change this. You want to start correcting it slowly. If something's happened over a very short period of time, there's perhaps more urgency to start saying, okay, let me address. But the main thing is to look at what's causing it.
Great, thank you for that, Prof. I think the last question that I want to ask is, someone is asking that in terms of bolusing with a balanced solution like Balsol, does bolusing with the potassium then not cause any problems? And that's maybe the same for another question that someone has posed about Ringer's lactate containing lactate. Is that not going to raise your patient's lactate?
So, I mean, the lactate in Ringer's lactate is metabolized to bicarb. So that's not an issue, that you won't get hyperlactatemia. I mean, obviously, in the patient who's hyperkalemic, you wouldn't want to give anything containing extra potassium. So it shouldn't be an issue. So in the patient who's passing urine and not with acute kidney injury, it shouldn't be an issue. If you're worried about that, then obviously an isotonic normal saline would be a better choice in those patients. And like we said, it's not a one-size-fits-all strategy. So there would obviously be exceptions to that. What is definitely not a good idea, which we do see happening, is patients bolusing with half Darrow's, which has got huge amounts of dextrose and 17 millimoles of potassium per liter. Which is a big problem. So that's probably more of a problem than your balanced crystalloid. But yes, I mean, obviously that makes sense. And I see there was also a comment about what fluid to use for your patients with cerebral edema. And again, I think an isotonic balanced crystalloid, something that's isotonic, that's not going to move into the intracerebral sort of cells is best, and there something without dextrose is better. So we prefer not to give dextrose to those patients, TBI sorts of patients.
Perhaps just a comment. I mean, if the lactate, if the potassium content of Ringer's lactate is 4 millimoles per liter, giving that amount of volume is going to make very little difference to the potassium concentration. And if your potassium concentration is already 6, it's actually going to bring it down. I do need to digress for a moment and remind people that we obsess about the serum content of potassium. The intracellular content of potassium is 130 to 140 millimoles per liter. And so, you know, if we can get some process that stops hemolysis, stops things moving out of the cell, and improves things moving into the cell, you will actually bring down the potassium fairly quickly anyway.
And if I can just add on to that, the Ringer's story. So we even use Ringer's lactate for dialysis fluid by adding glucose to it and to make it a dialysis fluid. And we don't worry about that potassium. It is minimal. And as Claire's also put in the chat, you often give lots of other things like blood with much higher potassium levels. So we generally bolus with Ringer's. That's our pretty standard. Small volumes, 5 to 10 mils per kilo. And then, as Susan said, reassess, reassess, and reassess.
Great. Thank you so much, everyone. Thank you to Prof. Argent and to Dr. Murphy for joining us. I think that was the great discussions. I just quickly want to have a little bit of a advert to you guys about our next webinar, which will be the end of November. And we will talk about resuscitation and a little bit of updates that's both there for neonates and children. And then we'll have a panel discussion about a little bit about the ethics of how long you resuscitate and what are some of our experts' experiences. So if you do have some time, please go and have a look at our website. There's some lovely resources, and I want to urge you to please become a SAPA member. And if you're interested, we do have some CPD points now for our webinars. And yeah, thank you so much for so many of you guys that stayed so long. And this will also be available on our YouTube channel later if you want to share with people. Thanks again for our presenters, and thanks for everyone that joined in. I hope you guys all have a lovely evening.
And thanks, Marty, for putting this all together.
Thank you. Thank you so much.
Thanks, Marty. Bye.